So I'm so excited that you're here today. We have an exciting presentation for you. I'm Linda Alpert-Gillis, and I'm the ambulatory chief for the Child and Adolescent Psychiatry Division. And over the years, I've gotten lots of questions about, you really see kids from birth to 18? What do you do with babies? So today you're going to get a chance to hear a little bit about what we do with babies and very young children. It's a population that's close to my heart because it offers a great way to not only help the infant and child that you're working with, but their families and siblings and extended families as well. So it's a wonderful population to work with, and you'll find out, what do we do with babies? And today presenting is Dr. Kenya Malcolm, who is Director of Infant and Early Childhood Initiatives for the Child and Adolescent Psychiatry Division, along with Karyn Hartz-Mandell, who is the Program Director for Early Childhood Consultation, and Jennifer Bruno, who is in a grant that she's going to tell you about, Rock Family Connect, and also a senior staff clinician in pediatric practice. So without further delay, here's Dr. Malcolm.
Good afternoon. I'm a little bit nervous being up here in front of you all. So if anybody else is a little bit distracted by their internal state, feel free to take a deep breath with me. Okay, I'm ready. We're just going to do a little bit of an introduction. Each of us is going to introduce ourselves very briefly. As Dr. Alpert-Gillis said, I'm Kenya Malcolm. I'm a clinical psychologist. I am the clinical director for our integrated behavioral health team over in Golisano Children's Hospital pediatric practice. I help to implement our Healthy Steps model, which you'll hear a little bit about from Jen. And then I spend some time helping to coordinate our caregiver programs through our pediatric behavioral health and wellness outpatient services. We've got two large locations, one at East River Road and one at South Ave.
Hello, everyone. I'm Jennifer Bruno. Like Kenya said, I am one of the senior staff clinicians over in the pediatric practice at Golisano Children's Hospital. I manage our Rock Family Teleconnects program, which I'll talk with you some more about. And I have a few different roles, all focused on early childhood support, that I'll share a little bit more during the course of our presentation.
Hi, I'm Karyn Hartz-Mandell. I'm a clinical psychologist at Pediatric Behavioral Health and Wellness, and I work in our outpatient clinic with young children and their families and some of our caregiver programs that Dr. Malcolm mentioned, and I'm the program director for our early child care consultation for child care centers. Turn back over to
So if you know me at all, you know that I have too many slides and too many tangents. So I'm going to maybe talk a little bit fast and leave some things out. Maybe this is going to be more of a teaser, kind of a discussion about some of the core components of infant mental health. But we'll review some of those. And then we're also going to look very briefly at the diversity-informed tenets of working with families and young children. Those were developed through the Irving Harris Foundation. So we're going to just maybe highlight a couple of those. So as we're going through some of those things, very briefly, just be listening as you're hearing about some of the programs that we're doing, about where some of those tenets are reflected in those programs. And then you're also going to hear about just a few of our current collaborations outside of pediatric behavioral health and wellness, not really outside the service, obviously, but outside of those traditional mental health clinics where we support families and young children. As Dr. Alpert-Gillis says, we are a service that serves 0 to 21 in the mental health space. Okay. So I have actually had folks say, infant mental health, I've never heard those words put in that order before. And that's okay. Also, when I was coming back from presenting at the World Association of Infant Mental Health, the nice man who was allowing me to get on the plane to leave Dublin said, infant mental health, that's what's wrong with the world today, infants mental health. So I figured that it would make a little bit of sense to talk a little bit, take a little bit of a step back to talk about this. Infant mental health as a field is multidisciplinary. And so if you look at the definition of infant mental health, it's pretty consistent with how we think about infant mental health in general. And it also isn't only inclusive of people who are providing clinical or clinically oriented mental health interventions, right? So we think about early childhood, early interventionists like OT and speech, pediatricians, our developmental pediatricians, and behavioral specialists is all part of the infant mental health field. And what we're talking about is a young child's capacity to form close and secure relationships with adults as well as with other children, to experience and manage a full range of emotions. So not just be happy, right, but also be able to be sad and frustrated, and to be able to explore their environment and learn. So hopefully that feels like we don't disagree, right, that we want people to be able to do that and that we're all working together. So I put this one slide about between 9.5 and 14% of children aged birth to 5 experience social and emotional problems. That's not a diagnostic statistic, right? And we're not only talking about those folks who fall within a range of pathology, because it's actually super hard to raise typically developing little children. I don't know if anybody else knows that that is true. Yeah, a couple of hands. Okay, great. And we want to be mindful of the idea that often families come to us and they're talking about things that are within the typical range for a 2 or 3-year-old, and it's really still disruptive, right? So there's a fine line between normalizing and dismissing, and we want to be mindful of the fact that it can be difficult even if it's typical. 69% of parents say that if they knew more positive parenting strategies, they would use them. That feels like a huge number, right? And 54% of parents wish that they had more information about how to be a good parent. The majority of parents also talk about being open to ideas about parenting, but being not that likely to bring it up with their providers, with their child's provider. So we can think about all kinds of reasons why that might be the case. So I have this video, it's only about 1.5 minutes. And I've been told to let you know that the sound is a little bit hard to hear in this room, but it should be fine for folks at home. So we have to put our listening ears on for this 1.5 minutes.
My 2-year-old says, Mum, could I have a banana? And I said, yeah, sure. He says, could you peel it? I said, yeah, sure. In the process of peeling it, I did what no parent should ever do to a 2-year-old. I broke it in half. And now he's like, I don't want that banana. Banana broken, new banana, and I had no more bananas. So I'm standing there in the kitchen, like you can picture it, right?
Yeah, okay.
And even though I'm a parent educator and I know what to do you think I did that? No, I did everything I could to avoid that emotion, because this is what our instinct is. This is what society says to do. So I said, I'll chop it up, I'll put it in a bowl, I'll put hundreds and thousands on it. He's like, no, new banana. So I tried logic. I'm showing him the bowl. Look in the bowl. There's no bananas. You can have an apple. New banana. I tried rice wheels. Tried the iPad. Probably said, have a look at some wiggles.
Yeah.
Look at the wiggles. He's like,
They've got a song about bananas.
Don't mash it.
He's like, no. He's on the floor. He's kicking and screaming. And like so many parents, I'm not finding that empathy or compassion. I wanted to yell, go to your room. And I didn't. It's actually a good story. I caught it, and this is what saved me in that moment from doing that, which is what my parents would have done. I said, I just remembered this one line, you don't need to fix it. You just have to let him know you get it. So I sat on the floor and I only said 3 things, and all I said was what happened. I'm just narrating what happened. I said, your banana broke. You really didn't want it to break, and you're really sad about this. Within 6 seconds, my son's head was on my shoulder. Within 7 seconds, I looked down. He's eating that bloody banana. Excuse my swearing.
No.
And I sat there and it blew me away, even though I've been practicing this stuff for 10 years myself through my work and through everything I've been learning. I sat there blown away at A, how well it works, B, how hard it is to do in the moment, especially under pressure, and C, I realised as I put him into bed that night and I went, oh, that was not about the banana.
So that was a parent's provider who was on the Wiggles. No, folks are familiar with the Wiggles, their podcast, sharing a little bit about what it's like to actually have a 2-year-old in the moment lose their minds over something that doesn't seem like it's that big of a deal, right? We've got all kinds of ways to solve the problem of the banana, and she realized that it really wasn't about the banana at all. But you can also see in that story the points where a disruption is probable, right? So, and she says, I just wanted to yell, just go to your room, right? And that probably wasn't going to solve the banana problem and was going to create different kinds of problems. So I'm just going to say these out loud with hardly any explanation. And again, be thinking about them as you hear about some of the programs. Optimal growth and development occur within nurturing relationships. The birth and care of a baby offer a family the possibility of new relationships, growth, and change. What happens in the early years affects the course of development across the lifespan. Early developing attachment relationships may be distorted or disturbed by caregiving histories of unresolved losses and traumatic life histories. We call these ghosts in the nursery. The therapeutic presence of an infant mental health practitioner may reduce the risk of relationship failure and offer the hopefulness of warm and nurturing caregiver responses. And family culture is present in all caregiving interactions. So these are some of the tenets that we really hold at the center of an infant mental health lens as we're thinking about training, the work, supporting others. An umbrella idea from this is really the parallel process. How are we supporting providers who are doing this work? I'll talk a little bit about that. Again, not going to give a lot of detail here. Infant mental health, infant and early childhood mental health approaches, those approaches that are informed and reflect an infant mental health lens are relational. They are multi-generational, so we know that babies do not function, develop, grow, learn optimally in a vacuum. There's a developmental orientation. What works and it makes sense for a 2-minute-old is not the same as what works and makes sense for a 2-month-old, a 2-year-old, a 12-year-old, right? We want to be developmentally oriented. It's multidisciplinary. No one is expected to know all of the things all of the time. And so intervention should really be multidisciplinary as well. And there's a prevention emphasis. Again, we don't have to have someone meeting major criteria in order to know that they're at risk for developing concerns over time. And we want to be able to intervene earlier rather than waiting. Many, especially clinically oriented services under this lens are dyadic in nature. So if you think about a child-parent psychotherapy kind of thing, or PCIT, which we'll talk about very briefly, they focus on unique, specially tailored services to a given child. It recognizes specialized training is needed. And we also, as young child providers, have to have a pretty good understanding about adult functioning as well. Right, so there's that piece that is really important too. And then this is that list. I said that we're just going to highlight a couple of these. I love every single one of these. And I encourage folks who work with children and families to go online and look at the diversity informed tenets for work with infants, children, and families. I'm going to just highlight number 5. We honor diverse family structures, which means that we don't hold one type of family as superior, and that we don't, so then we're not trying to talk people into having the kind of family structure that we think they should have. We let people tell us who is important to them, and we include them when it makes sense to.
So I'm just going to highlight number 6, understand that language can hurt or heal. So there's power in language, right? And in different modes of nonverbal communication. And that language and those words can either divide or connect. They can hurt or heal. So it's important to be mindful of the words we choose and the choice of materials or images we present to families in order to most inclusively support all children and their families. So we really try to choose inclusive terms like caregiver or birthing parent rather than just mother, and also include images of fathers in our materials, and also really work to include all caregivers in conversations that are centered around the baby or the dyad.
And I'd like to highlight tenet number 8, which is allocating resources to systems change. And this really captures that children exist and develop within many systems. And in order to truly address inequity and disparity, it's really essential to invest time and resources into reflection, identifying bias, addressing barriers, and preventing systems of oppression from being inadvertently reenacted. So in early care and education settings, we are working with classroom systems, center systems, family systems on behalf of a child. And a systems issue that comes up often in early care and education settings nationally is the use of exclusionary discipline practices, such as a child being sent home early for their behavior or being expelled and asked to leave the program. And these practices are experienced at much higher rates by boys and by Black and Indigenous children and children who have experienced early adversity. And so consultation can help in identifying potential biases in the systems and creating inclusive policies and practices to help reduce these disparities. And I'll get to share a little bit more about this consultation work a little bit later.
Thank you very much. All right, so over at PBH&W, we have lots of things going on that we include our little kiddos in. We have individual therapies, we have some group therapies. We have a new pilot that's happening for 4 to 6 year olds with music therapy, which is bonkers and so amazing. I know that that's going to go wonderfully. And then we have a growing number of caregiver-specific programs, which I'm going to put up as a slide, mostly because I love it so much and want you to see it, not because it's actually what I wanted to talk about today. And then when we think about, again, supporting staff, we have implemented reflective supervision and consultation groups. So here's that slide that is really just a bragging slide. I want everyone to know that we do offer caregiver-specific programs through our clinics. A couple of them, so Caregiver Connections program, that's a program that we had some grant funding to initiate, had folks go through some training. It uses the reflective parenting curriculum. We do that in a group format. Dr. Jess Keith is over our Ruby parent training program. And Dr. Abby Rosen is over our, Lauren Mutignani is over our parent-child interaction therapy program. And then we also have 2 newish programs. Dr. Rosen does our SPACE program, which is for parents of children with anxiety behaviors and a lot of accommodating behaviors that they're doing. And then our allied caregiver group is for caregivers of teens on the transgender spectrum. So again, we're not talking about this, but I want you to know that it's happening. And then reflective supervision and consultation is a special type of supervision for, again, a multidisciplinary group of folks that allows for opportunities to think about how we are impacting our work and how the work is impacting us. So again, if you think about that example we saw on the video, and make a parallel of what that's like to work with that child and that family in clinical work or in direct intervention work, it can be a pretty frustrating situation, right? And it's hard to consistently show up in equitable ways for folks when we're struggling a lot with the last interaction that we had with them. So we do have 2 groups that are running right now, one for direct clinical staff, which Karyn facilitates, one for supervisors who supervise those direct clinical staff, which I facilitate. And then again, because we believe in the parallel process, we're all also involved in our own reflective supervision groups, primarily through a local organization called the Society for Prevention and Care of Children, who are involved with capacity building for infant mental health professionals in Rochester. And why that's important is because it is not possible to work on behalf of human beings to try to help them without having powerful feelings aroused in ourselves. And this is a picture from a few years ago at the border between, I think, Texas and Mexico. It may be New Mexico and Mexico. And the story around this picture varies online. But what you can see is a grown-up being frisked and a little child in the midst of that. And it can be hard to hear those stories, and that's why we really value reflective spaces. All right, so the things we're actually going to talk about today start next. We do have a number of satellites where we also see young children as part of our regular kind of care. That's 3 pediatric offices, some subspecialty care, and then our expanded school-based program, which Karyn's going to talk about, our early childhood stuff there. So those are the programs that we're going to, we're going to highlight. Jen is going to highlight her program and how it clicks into our Healthy Steps work. Karyn's going to talk about that early childhood consultation at our local WISE. And then I'm just going to very briefly at the end let you know that we have also started a new collaboration with Breastfeeding Medicine.
Okay, so one of the ways that we identify families for early child support is through screening. So I'm going to talk about some of the screening that we do in the pediatric practice. And so there's screeners, everyone gets screened for social determinants of health at every well child visit, all of the ages, but I'm going to focus in on our early childhood screening listed here. So the Edinburgh Postnatal Depression Scale, or EPDS, is a 10-item scale that screens for anxiety and depression symptoms in the postpartum period. It's widely given to mothers, but there's evidence to support its efficacy with fathers and other primary caregivers as well. The pediatric symptom checklist, there's a baby version and a preschool version. So the baby PSC screens for concerns in 3 categories. So flexible, like being in places or being with new people. Comfort, so things like irritability and the ability to calm. And routines, which mainly focuses on sleep. And then the preschool PSC asks about a child's feelings, behavior, and how parents are able to respond to their child. And then there's the ASQ, or Ages and Stages questionnaire, that assesses development and if children are on track for their given age in the areas of communication, gross motor, fine motor, problem solving, and personal social. And then the MCHAT assesses for possible concerns for autism. So there's also some additional screening that we do that's focused on our newborns, and that's primarily through our Rock Family Teleconnects program. So this is a program that's community-wide. It's in a partnership with Rochester Regional Health and Anthony Jordan Health Center. And right now offered through Golisano Children's Hospital Pediatric Practice. So it's a universal program that we offer to all of our newborns. There's no referral criteria or anything like that. And so this is a model that's based on a model that was developed at Duke University, the Family Connects International model, which was originally given as a home visiting model. And so when the pandemic hit, we transitioned to a telehealth model, and we've continued to deliver this in a telehealth format. So this program includes a community health navigator who's located in our pediatric practice. And so she meets with all of our newborns at their first newborn visit as much as possible. If not, she'll follow up after their visit. And so she meets with them. She lets them know about our program. She provides some psychoeducational materials about when to call the doctor, baby care. She asks about feeding, breastfeeding. She asks about any other needs that the family may have. And then she'll schedule that initial visit, which is with one of our pediatric practice nurses. And so that's done over Zoom. And we try to have that visit occur within 30 days of baby's life, because it's really meant to be an early connection to care and really help screen for some additional things that may be going on and really assess mom's health and baby's health. So in that initial nurse video visit, the nurse does some additional screening. So that includes a breastfeeding assessment, an intimate partner violence assessment, substance use screening, tobacco use screening. They review the social determinants of health screening, look at postpartum care planning, and then either review or complete the EPD-S again. So I'm going to talk a little bit more in depth about what our support looks like within Rock Family Teleconnects for the behavioral health piece of that. So I mentioned that I have a few different roles focused on early childhood within the practice. And so one of those is to provide the behavioral health support through Rock Family Teleconnects to caregivers who do identify some postpartum mood or anxiety concerns. So typically when the baby and caregiver have their initial nurse visit and they complete all of the screening, if the EPD-S is elevated or if caregivers just identify some concerns, either with mood or stress or family adjustment or those kinds of things, then they'll refer to me, and our community health navigator will reach out to the family to schedule either a video visit or to meet in the office, whichever the family prefers. And then at that visit, we'll discuss, their mood and any stress-related concerns, what it might be like adjusting to having a baby, discuss coping strategies that might be helpful. I will ask about past mental health history to get a sense of what that's like and what may be helpful moving forward. And it's really meant to be a brief, supportive counseling service to help either bridge care to a longer term support or to provide some of that additional support early in the pediatric space. So I will always ask about their interest and connection to a longer term service, which could be Healthy Moms or Building Healthy Children or one of the other early childhood focused community resources, or a traditional adult mental health clinic. And then we have also formed a collaboration with the behavioral health care manager over at the gender wellness OBGYN practice. And so a lot of our caregivers receive their OB care through GOG. So I'm able to coordinate with her and she can help facilitate connection to mental health and gender wellness that's located over at the same location as the OB office. So this has been really helpful because moms and caregivers typically show up in the pediatric office much sooner than they follow up at OB. And they tend to prioritize their baby's care over their own care. So it's been really nice that we're able to meet them right there and provide that support right in the pediatric office. So once families complete 3 or 4 visits with our nurse in the Rock Family Teleconnects program, they're often referred for some ongoing support through Healthy Steps. So Healthy Steps is a model of integration for pediatric primary care offices that focuses on child development, social, emotional, and behavioral screenings, child development and behavior consults, care coordination and systems navigation, positive parenting guidance and information, early learning resources, and ongoing preventive team-based well-child visits. So Healthy Steps is a tiered model that ranges from more prevention-based screening and support in Tier 1 to more intervention-based support in Tier 3. And families can move among these tiers and kind of receive whatever level of support they might need. So Tier 1 is considered those universal services which everyone in the practice receives. And so that's the screening, access to additional development handouts and resources and things like that. Tier 2 is considered more like a short-term consultation or check-ins at well-child visits or sort of an extension of the well-child visit where the Healthy Steps specialist is talking with families about development, feeding, sleep, those kinds of things a little bit more in depth. And then Tier 3 is our more comprehensive services, include more frequent meetings, more dietic therapy in collaboration with additional team members. And lots of times this is referral based through the primary care doctor. Lots of those referrals are often for tantrums, sleep concerns, Feeding concerns could be picky eating or weaning from breastfeeding, and then just overall family adjustment. And so our integrated behavioral health team provides these tier 3 services in response to some of that elevated PSC screening, or if concerns come up in a well child visit with a PCP. And so we have 2 team members that have a special focus in early childhood, myself being one of those and one other person. And so we see the majority of those 0 to 3 referrals. Our work is dyadic. It utilizes that reflective practice and infant mental health informed orientation. And we're often collaborating with other teams, including our social work team, our care coordinators, the PCPs, of course, and then other community supports. So now that I've discussed some of the ways that we provide support for our littlest patients, I'll walk through a case example to show kind of what this might look like in practice. So Bella comes in for her newborn visit with her mother. She's 3 days old, and her baby and mom were just discharged the day before. So our Rock Family Teleconnects Community Health Navigator meets with the family and introduces the program, provides that welcome bag with some diapers and other baby resources, asks how feeding's going and those kinds of things. And then mom's agreeable, so they schedule a nurse visit for about 3 weeks from that visit over Zoom. So mom and baby attend the video visit with the nurse, and she completes all of that comprehensive screening and assessment around mom's health and baby's health. And so mom scores a 12 on the EPD-S, which is considered elevated, and is referred to the behavioral health specialist for some of that brief support. All of the other screenings were negative, but she's a first-time mom, and so she's asked a lot of questions about how to care for the baby, so the nurse is able to answer a lot of those and support her around that. So Bella's coming in the next week or so for a follow-up weight check. So the behavioral health specialist meets with mom and baby at this visit. They talk about her mood and adjustment to having a baby. She does not have a lot of family support, and the baby's father's not involved. They've had a conflictual relationship in the past. So mom also received her OB care through Gender Wellness, OBGYN. So the behavioral health specialist is able to coordinate with the behavioral health care manager over there with mom's permission and help link her to some longer term behavioral health supports through the OB office. So because that can take a little bit of time, the behavioral health specialist continues to meet with mom for 2 more sessions. And then at that point, she has an initial appointment set up with a longer term therapist. So Bella and her mom follow up again with the Rock Family Teleconnects nurse when Bella's 3 months old. And they do some follow-up assessment, and the nurse provides some psychoeducation about development. Mom's planning to return to work, so they talk about that upcoming transition. And she identifies that she needs some assistance with childcare. So the nurse connects her with a social worker in the practice to help support with this. They follow up with the nurse again at 5 months. And so this is the last meeting that she'll have with the nurse, because the Rock Family Teleconnects program goes through 6 months. But because mom has a lot of questions, the nurse thinks it might be helpful for her to follow up with a healthy step specialist for some ongoing support. And so the healthy step specialist is able to meet with them at their 6-month well child visit and plans to follow up at the next well visit. So they're able to meet at most of their well child visits and just talk about development and how Bella's growing and all of those kinds of things. And then when mom and Bella come in at the 24-month well child visit, mom lets the doctor know that she's having a lot of tantrums, that she just doesn't know how to respond to that. It's feeling really unmanageable. And so mom and the healthy step specialist make a plan to meet more frequently for some of that short-term behavioral health consultation, really focused around helping her manage those tantrums and helping her respond to those in ways that feel more effective. So this is just an example of how Rock Family Teleconnects can kind of flow into healthy steps, and how there's collaboration with the other integrated teams in the practice. So sometimes families don't stay connected this long with someone, but that just kind of shows how at different ages and developmental stages, how that support will look within the pediatric practice. Some families certainly do stay connected this long. And what's nice for myself, because I have these kind of dual roles or whatnot within the practice, some of these families I'm able to follow through 3 years old and provide the support in various ways depending on what the level of need is. Great. I'll turn it over to Karyn.
Thank you. So through our expanded school mental health program, we partner with the Greater Rochester YMCA and their 4 full-day childcare centers that serve children 5 and under. And our consultants partner with the educators, center directors, and families to foster children's social emotional well-being and address concerns early when they arise. So in contrast to traditional direct service, outpatient therapy, our consultation is an indirect support for child mental health, in which we are partnering with the adults who interact with children in their day-to-day in order to build the capacity of those adults to support children's mental health. So an early educator, for example, with this increased capacity has the potential to positively impact an individual child, but also the other children in her classroom and children in her classrooms for years to come. So consistent with the infant mental health and diversity informed tenets that Kenya shared earlier, we take a highly collaborative, strength-based approach to really promote supportive, responsive relationships and environments that in turn support positive outcomes for children. So consultants can provide support around social, emotional, or behavioral concerns for a particular child, maybe difficulty separating at drop-off or biting, or an issue coming up throughout the classroom, maybe behavior that's disrupting circle time is happening often. And consultants can also provide programmatic supports. So for instance, one of our consultants has helped a center to implement social and emotional screening in order to identify kids who could use some additional support early on. And as consultants collaborate with educators and families to understand their concerns and how they could be addressed, we're always considering multiple levels of influence, including the child and individual family characteristics, classroom dynamics and relationships, and program factors like the center culture and climate. And a core aspect always of consultants' work is to support equity and inclusive practices in line with those diversity-informed tenets that we highlighted earlier. So in addition to issue-specific consultation, we collaborate with center leadership to offer workshops for educators to support their knowledge, skills, and confidence in supporting children's social emotional development and addressing behaviors that are perceived as challenging that come up in the classroom. Our partnerships with families are also essential. We meet with families when their child is referred for consultation, but also offer support broadly at the centers. This has ranged from providing participating in open houses to share our services, to being available around pickup time, to provide resources on common social emotional topics, or to offering a weekly parenting program at one center. Within each of these areas of support that we can provide to centers, the specific activities and topics are really tailored to the unique needs of each center. My colleagues at the Georgetown Center of Excellence for Infant and Early Childhood Mental Health Consultation have developed this theory of change, which really illustrates the indirect nature of this service. Prior to coming to University of Rochester 3 years ago, I worked at Georgetown and have been very fortunate to continue to collaborate since moving here. And this theory of change that they developed really highlights the central role of consultants' relationships and how they approach the work, in addition to the specific activities that they engage in for promoting positive outcomes for children, families, and for early childcare programs. This theory of change really applies to consultation in a variety of early childhood settings, home visiting, child welfare, early intervention, or primary care. And today we're really applying it to our work in the child care centers. This consultative stance captures how consultants engage and approach the work. This is really consultants' way of being in the work. And you'll notice common themes here with the infant mental health principles and the centrality of relationships, considering multiple levels of influence, and the importance of the parallel process. I also want to highlight avoiding the position of the expert and wondering instead of knowing as ways that consultants facilitate collaboration, and valuing the knowledge, experience, and perspective that all members of the team bring. Consultants bring this stance of how they approach the work into all of the specific activities that they engage in, or what it is that they do in consultation. And so what these activities look like in practice is that a center director initiates consultation by referring a child or classroom. So for example, a director maybe is concerned about a toddler who started biting frequently in the classroom. So she talks with the family and obtains their permission, and then submits a referral form to us. The consultant then completes an initial assessment, including a classroom observation, meetings with the director, teachers, and family to gather each person's perspective. And the consultant then shares information back to start to build a mutual understanding of the child's behavior with this team. In this example, the consultant may have identified that the child started biting following the birth of a younger sibling. The child is speaking less than we would expect at this age, and some of the older children in the classroom had been engaging in some biting when the child first moved into this classroom a few months ago. So the team then establishes goals for consultation, which in this case would likely include reducing the frequency of biting and increasing how often the child's using appropriate alternative strategies like verbal or nonverbal communication. So the consultant then engages in a range of activities to support progress on these goals. Consultants meet with the teachers, which could include discussing behavioral strategies. In our biting example, this might include identifying the function of the behavior, as well as ways to teach the child alternative behaviors and reinforce these behaviors. The consultant may also share some information about how common this behavior is at this age and common reasons why children bite. But importantly, consultants also really try to understand the teacher's experience, how that might affect her interactions with the child. For instance, this teacher may have had complaints from multiple parents of children who had been bitten, and this teacher feels like she's failed in her responsibilities every time that a bite occurs in her classroom. So in addition to behavioral strategies, the consultant can support the teacher around her expectations for herself and her role, managing her stress and her emotions when biting occurs, identifying strengths, and collaborating with her co-teacher for some support. The consultant can then follow up to provide in-classroom support and observations to help facilitate the implementation of these strategies, monitor progress, and check in on the teacher's well-being. For this child, the consultant may also partner with the child's family to facilitate a referral to early intervention for a speech therapy evaluation and support the family with ways to help the child adjust to having a younger sibling. And then throughout this process, the consultant is engaging in programmatic consultation to support the capacity of the entire center. So in this case, the consultant could meet with the director to share the strategies discussed with the teacher so that that director can be checking in and supporting the teacher in between the consultant's visits. And the consultant may also work with the director on ways to communicate with families and collaborate with them around biting. This programmatic support could also include reviewing the center policies to ensure that they're inclusive and equitable, for example, avoiding sending children home for biting. And finally, the director and consultant through these conversations may identify that actually many of the staff in the center, not just this child's teacher, are struggling with how to manage their own emotions and reactions when behaviors experienced as challenging in the classroom occur. And so they could plan a professional development workshop to support teachers with that. The consultation is then ended when consultants, staff, and families all agree that the goals for consultation have been achieved. So in this case, perhaps the child is biting less often and the teacher and director feel confident in ways that they can support the child and the family has connected with early intervention. So as we are in our third year of this partnership with the YMCA, we are looking ahead towards our next steps and pursuing ways to grow our consultation program. In collaboration with the Y, we've applied for additional funding to further develop our program infrastructure and to develop some training procedures that will allow us to add more consultants to our team and to expand our existing services, particularly the workshops that we're able to offer for teachers and families. And we plan to expand these services at the current centers that we're partnering with at the Y, as well as to explore partnerships with additional childcare centers in the region. In addition to our childcare program here at U of R, we're also working on building the consultant workforce nationally. So with colleagues at Georgetown, we developed a professional certificate program through their School of Continuing Studies. And this certificate program is a way to build the capacity of consultants engaged in this work in a variety of settings and programs across the country, and to increase the consistency and that foundational knowledge and grounding in how this work is done on behalf of young children as the number of these consultation programs continues to grow. And finally, in order to continually improve the quality of ours and other consultation programs and expand the growing evidence base for this approach, we're engaged in some research and evaluation efforts. And these efforts are focused really on better understanding for whom and under what circumstances consultation leads to the most positive outcomes. So in particular, we're examining mechanisms of change, including the consultative relationship, investigating ways to improve our measurement of consultation outcomes, and how we can measure implementation fidelity in a highly individualized service like this, and considering other implementation factors such as what dose of consultation is needed to produce the desired outcomes. So thank you so much for sharing about this, and I'm going to turn it back to Kenya.
Hello again. So just very quickly, our newest consultation is with breastfeeding and lactation medicine, which is a division in pediatrics. We're still figuring some things out. For those of you who provide consultation and training, you know that when you start a new relationship, the other agency, the other group of folks tends to focus on those highly emotionally salient incidences that have happened, but don't happen very often, right? So you can't build a program around the one thing that really upsets everyone every 6 months. So it takes a little bit of time to think about what are those things that are really helpful for us to think about in an ongoing way. We do have some grant funding that we're using to help fund our time there. And that looks similar to what we've been talking about, both the direct intervention level as well as a consultation to the team level of care. We've done some additional training in order to be able to feel like we're doing this effectively. And the service right now looks like a brief time-limited consultation directly to the caregiver or families, particularly around those issues that come up when you've got a new baby. Somebody hands you a new baby and tells you to keep it alive, and you're not entirely sure how to do that, right? But because they're also involved with breastfeeding medicine, there are concerns happening, right? So breastfeeding's not going the way that they thought. Maybe parenting isn't going the way that they thought. Maybe their relationship with their partner's not going the way that they thought. And some support around that is really helpful. It also gives us an opportunity, the consultation level with the team gives us an opportunity to help the entire team have a broader view of how they're conceptualizing both breastfeeding as well as family care. I know I'm required at least once a week to say biopsychosocial model. So we're able to help folks think about that using that breastfeeding lens. And most of the follow-up that happens directly with caregivers is virtual right now, which actually works really well. They don't have to pack up all of their young children and their young children's things. So they really appreciate that, but we can do warm handoffs when we're physically in the clinic, which has helped us to link to those families. Here's a few logos of our friends, funders, and partners. And also shout out to the folks who are doing very similar work on the maternal health side. Because dyadic work is a sticky wicket when there's one system that's in charge of a baby's body and another system that's in charge of the grown-up's body. So we try and keep the collaboration channels open with those colleagues as well. Oop, and I hit something. Sean, no. I don't know how to get that away, but that is the last slide. Like right on the screen. I did that. Oh. Right. Yeah, except for this one. So when I got the title of Director of Infant and Early Childhood Initiatives, I called it the Baby Club with affection. And these are some of the other Baby Club members at a training that we did last year, I think. So I really appreciate all the people when I was like, hey, we're going to do this thing. And they're like, yeah, I want to do that too. So that's one of the things that I really love about pediatric behavioral health and wellness. So we can take I don't even know what time it is. A couple questions probably, but not if they're too hard. Oh, we get a class? You can. Any questions? Happy to, yes. Yeah, thank you for that question. Oh, sorry. Hello. The question was about funding and sustainability. So at different levels, right? So there are some things that we're doing that are still under some grants. So implementing Healthy Steps was part of a 5-year community grant through SAMHSA. We're at the end of that grant. We're in the no-cost extension phase right now. So we really had to think about how we were going to implement that in a sustainable way, and mostly we've done that. The caregiver groups started off with some funding to support while we were doing it, and also having leadership that is really in support of that really helped, because there were some times when there were costs we just had to eat those, and someone had to be okay with that. But since that time, parent groups are now reimbursable. That's been only within the last 2 years. So that's been great. There's also been a clarification of a diagnostic code that feels more comfortable with babies than depressive disorder, for example. It's a preventative code and it's a Z code. So we've gotten some clarification in the state that we can use that. And we bill a lot of especially within that first 12 months, using that diagnostic code so that we can continue to use individual and family therapy codes for a lot of those higher levels of care. So combo.
Yeah, I think talking about sustainability right from the beginning before we initiate anything new is super important to us, because we don't want to introduce something and then have to remove it either from our services or from the community. So looking at sustainability is so important. Any last question? We could take one more question. Sephora.
Yay.
Orientation, not only for kids, little ones, but also their parents. I'm thinking about longitudinal measurement of depression symptoms. Can you say a little bit about arriving at the Edinburgh versus the PHQ, for example?
I can say a little bit about that, and
Repeat the question.
oh, sorry. So the question is around using the Edinburgh versus the PHQ, particularly being able to look across time longitudinally. We landed on the EPDS mostly because we were already using it in pediatrics. And one of the things that's been really hard about using any measure for maternal health is that from the pediatric side, nobody thinks we should be asking moms anything anyways. So the questions around whether or not we have a mom or dad answer a PHQ, and that's going to inform their chart is a whole separate thing anyway. We don't have access to that. So the issue of longitudinalness has been sort of like on a bottom priority. But I can imagine that it's going to come up, particularly breastfeeding medicine does both. So we haven't had to, really make a hard stance, but the EPDS had been implemented on AC6 as part of a QI project a number of years ago. And so we've just been using what they use. And I think the Teleconnects program, they're using it across the collaboration that they're using as well. Yeah.
All right. Well, I want to thank Dr. Malcolm, Dr. Hartz-Mandell, and Ms. Bruno for a wonderful presentation today. Have a wonderful day.